Sir, we welcome you. Yes. So the chief guest of today's function is Dr. Raj Kumar, Deputy Director, Mother and Child Quality Assurance, Department of Health and Family Welfare, Government of Karnataka. We wholeheartedly welcome you, sir.
Thank you, madam. Thank you.
So we have special invitees today, Dr. Y. Ramesh Babu, the DHO of Ballari. We wholeheartedly welcome you, sir. And we have the RCHO of Ballari, Dr. Hanumantappa, sir. We also welcome you, sir. And now the speaker of today is Dr. Medha Sushma. She is a fetal medicine consultant from Telangana. We wholeheartedly welcome you, madam. I welcome all the members of IMA AMS, our Secretary of IMA AMS Karnataka State Branch, Dr. Suresh Kagalkar. I welcome Dr. Srinivasalu, President of IMA Ballari, and Dr. Raghavendra, Secretary of IMA Ballari, and all the members of IMA Ballari branch. I welcome all the members of IMA Karnataka State Branch who have joined for today's CME. I welcome one and all. Now, I request Dr. Raj Kumar sir to be introduced by Dr. Sangeeta Kattimani, who is the Joint Secretary of IMA Ballari, following which sir will be addressing us all.
Thank you, ma'am.
Dr. Sangeeta.
Yeah, thank you, ma'am. Dr. Rajkumar, sir is a Deputy Director of Maternal Health and Quality Improvement. Sir is State Nodal Officer for implementation of various maternal health and quality improvement schemes like Janani Suraksha Yojana, Janani Shishu Suraksha Karyakram, Pradhan Mantri Surakshit Matritva Ashvasan, Midwifery Initiative, Laksha Program, Kayakalpa Program, and NQAS. The objectives of these programs is to improve the maternity care and newborn care in Karnataka, and also to reduce the maternal mortality ratio to acceptable levels and enable NQAS and Laksha accreditation of public hospitals. Sir has immensely contributed for the national guidelines and manuals for maternal health and family welfare schemes. And sir has been National Assessor for Laksha and NQAS. We welcome you, sir, to our CME today. Thank you.
Thank you. Thank you, Dr. Sangeeta Kattimani, and all others who have welcomed me for this prestigious webinar or edition, what we can call at our level. And at the greetings from the Department of Health and Family Welfare, Government of Karnataka, especially the National Health Mission and the Maternal Health. Wholeheartedly, actually, I am very much pleased to as meeting gathering, and I thank everybody for giving an opportunity to be the guest on this occasion. Being an obstetrician and at the state level, helming the program of maternal quality, it gives me pride addressing this gathering about an issue which is heartful to us. And in the last many years, traditionally we have been telling the causes of maternal death are the then coming to the hypertension disorder, pregnancy, and of course infection, and then the others, embolism and minor cardiac disorders and other things. For the last many years, rapid has been made in the prevention and control treatment of postpartum hemorrhage by way of the drugs utilization, by way of the active management of the third stage of labor. But when it comes to hyper disorders in pregnancy, or we have been calling pregnancy-induced hypertension, under the gamut spectrum, we have mild preeclampsia, severe preeclampsia, so on. So, particular segment the postpartum hemorrhage in terms of the maternal death. Maximum causes of maternal death are attributable to hypertensive disorders in pregnancy over the last 1 to 2 years. Now, for that, rightfully, you have been observing, you have taken the lead and observing the World Hypertension Day back and Preeclampsia Day. I think it pays to do this because, as you have observed, it has occupied the foremost place in the causes of maternal death, and really you have thought very well to observe this day, see that it catches the attention of all the stakeholders, be it at the policy level or at the level of healthcare provision, whether it's government or private. So coming to the pre-eclampsia issues, why we are not able to make this a cause which is coming down. Rather, it is not, still it is occupied. In fact, overtaken the PPH. And for this pre-eclampsia, eclampsia, the gamut of hypertensive pregnancy, what needs to be done? What are the gaps? As I've observed, in my opinion, I'm here at the state level for the last 10 years. In fact, 8 years as DD maternal health and quality, and I have observed that still detection itself is questionable in the sense that it's not complete. The way we have to detect hypertensive disorders in pregnancy, what we say there is that monthly we have to get hemoglobin estimation and urine albumin done for every monthly ANC visit. We need to do this at wherever the woman goes, mother goes. Hemoglobin estimation for anemia. For the measurement of BP cannot be overemphasized, as it is very much important. Suddenly, it can't become a pre-eclampsia or eclampsia without going through the stage of before hemoglobin is so probably will shed us give us some light to how the disorder be in the offing. So what I would like to reiterate is that there can never be any replacement for detection of hypertension. Use we are having understandable, and they are of course near examination. A suggestion is that we should not the ANC. In ANC, it also had our where we have to tell the detecting the case, asking her to take the tabs, because all of you are in the practice, you will be knowing that a patient sometimes when disclose that suffering from GDM or PIH, they don't agree first vomiting, oliguria, blurring of vision. When these things occur through systematic BP estimation as well as urine albumin estimation, when we declare BP or PIH, what they would like to first instance is always. Am I audible? Hello?
Yes,
hello,
sir.
am I audible?
But the audio
Yes, sir,
is
audible.
poor, sir, very poor. Yeah, I stopped your video, sir. You just speak, we'll see.
And even there is okay, shall I yeah, I will cut down the video. Is it...
Yes, sir, please.
Yes, sir. Go ahead, sir. Go ahead. Now
Yes.
it's
So
audio is
even established PIH, people are not. Yeah. Okay. PIH, people are not.
John, we can't hear, sir, actually.
The intention is that the moment BP or...
Sorry to interrupt you, sir. Your voice is not coming, sir.
I
Your
am willing to take
network
the time.
bandwidth is very much low. You are facing net.
Rajkumar sir, his audio is gone. Geeta ma'am.
Okay.
Am I audible, madam?
Now, sir.
Yes,
I'm very sorry.
Now.
I'm very sorry. Okay. So I will. Shall I cut down the video? Shall I stop the video? Only audio, so that frequency.
Yes, sir.
Is
Only
it
audio
okay?
would be fine.
Yes, sir. Thank you, sir. Thank you. So what on our part is that number one, detection, screening of all pregnant women for BP at all checkups. No, we have come a long way now. Changes less agile, and so therefore they are more prone for hypertensive disorders, and also given the diet which people are taking at some places, so it's very pertinent for us to see that we estimate the BP very correctly at every visit, and then thereafter counsel the mother as to how the BP, how the treatment for PIH is very much important in saving her life. So, and then thereafterwards, constituting the treatment for us. Now, even the treatment of the preeclampsia has, of course, changed a little bit. Okay, alpha methyl dopa, which was there, now has given way to the primary private. What I would my suggestion is that we have to detect at its infancy, so that the mother is optimized when she comes to labor, so that she can have a very fruitful delivery and eventual outcome of a very pleasing outcome, where we have seen that the mother and the fruit which she was all along trying to see at the end of 9 months, that is the baby, is achieved, and the dream of every mother to give birth to a healthy newborn is achieved. So therefore, and also the reduction of maternal death also plays a I would congratulate all of you for, first of all, coming under one roof, giving a thought to this menace of preeclampsia, eclampsia, and under the hypertensive gamut, so that we don't lose mothers. At the end, I would like to say that every woman always will conceive during the prime of their health. So at the outset, they will not be suffering from any of the major disorders, but due to pregnancy. So she develops hypertension. So it's our duty to see that we save this mother who, in the pink of her health, has consented to become pregnant for the sake of the family as well as the civilization. So in this context, I would my earnest request to every one of you who have come here, assembled here, gathered here, is that you have come. The first step has been taken in first discussing the issue, and thereafterwards, let's once again come across whenever it permits and see that we reduce the deaths to an acceptable level, because if they are happening because of due to hypertensive disorders, I think this is one of the preventable.
Hello.
It's quite a this disorder is treated very. Am I audible, ma'am?
Yes, sir.
Hello.
Yes, sir.
Hello.
Yes, sir. Yes, sir.
Yes, sir. But the voice is breaking.
Voice is breaking, sir.
Given us to be with this lady during the course of the journey of 8 months. It is well. It's a okay. So
yes.
it's a good time for us. And would be able to whatever topic. So all it is with the MMR. For this, the district health
Geeta ma'am, sir's audio.
Yeah,
is
sirs. Yeah, we are not able to.
very
sorry to
poor
catch up last few minutes. I would like to
No,
end.
we are able to hear you, sir. Yeah.
You are able to hear you, ma'am? You are able to hear me?
No, sir. No, sir. In between, it
Hello?
is going, sir. Hello, sir.
The network is very poor, ma'am.
Yeah, that's what. Just one line we are able to hear.
Sir told he is traveling.
Oh, sir.
Shall we take his voice message, madam? If anything wants to convey to the IMA, shall we?
Yeah, surely. Okay.
Sir
Just
wants
ask
to
that.
convey something to the
So you are
IMA.
able to hear. I would like to.
Yes, sir. Please, sir.
Yeah, sir.
Then leaving the entire thing to the think tank of Ballari to see that maternal deaths are brought down, especially due to on
Raghavendra?
Yes, sir.
We can't hear actually.
Yes, sir.
Yeah.
Oh.
I think network is the problem.
Yes. Yes, sir is left. Okay. We'll see if sir joins. Thank
You
you,
can
Dr.
record it
Rajkumar,
and
sir.
send it.
Yeah. Thank you, Dr. Rajkumar, sir, for your valuable guidance and talk. Now I request our President, IMA Karnataka State Branch, Dr. Srinivas, sir, to address the gathering.
So, good evening, everyone. So, Dr. Geeta Dappa Madam, our Secretary, Karnakar, just now we read about IMA prayer. So, and Srinivasulu is there, and our President Raghavendra is there, and I have to thank Dr. Rajkumar, Deputy Superintendent, for narrating so many aspects about toxemia as well as hypertension. And Dr. Sangeeta is there, and Dr. Kagalkar is there, and so many dignitaries there. So, and today's speaker, Dr. Mera Madam is there. She's there. She's speaking from Telangana, very nice of you, Madam. And without much wasting time, and definitely I'm going to hand over this to Geeta Dappa Madam, so that to continue the program. Actually, today is very good program they have arranged. So, with respect to hypertension day, definitely I am very proud of you people. Definitely everything is doing well. All subcommittees in our state is doing very well. Thank you very much. Go ahead, madam. Please continue. Madam.
Thank you, sir. Thank you for your address. Yes. So now, today's speaker, Dr. Mehta, will be talking. So before that, I request Dr. Raghavendra to introduce Dr. Mehta. So today, as we know, we have the World Pre-Eclampsia Day with the theme of Predict, Prevent and Prevail. So over to you, Dr. Raghavendra.
Yeah, thank you, madam. Yeah, before introducing and inviting Dr. Sushma, I would like to say few data on this preeclampsia. The theme of World Preeclampsia Day is Predict, Prevent and Prevail. And the perinatal mortality rate, as per the report of National Family Health Survey, NFHS 5, the perinatal mortality rate is 32,000 per pregnancies, and neonatal mortality rate is 25 per live births. And they are majorly attributed to the low birth weight and prematurity related to the hypertensive disorders in pregnancy. And 50,000 to 60,000 maternal deaths per year are due to hypertensive disorders in pregnancy. And having understanding this magnitude of problem, I would like to predict some optimistic approach. Annual pregnancies in India are 30 millions annually. Out of this, approximately 8% are at risk of developing preeclampsia. If we screen for the preeclampsia in all pregnancies using maternal characteristics and history, with 50% of the detection rate, 12 lakh pregnancies will be identified at the risk, And if you use maternal characteristics and mean arterial blood pressure, the detection rate will reach 70%, and 16 lakhs pregnancies will be identified. And if you add uterine artery PI, 82% detection rate, and 20 lakh pregnancies will be identified as the risk for the preeclampsia. And if you start them on low dose aspirin, 80% of this pregnancies will benefit annually. So, having understanding this magnitude of the problem, IRA has launched Samrakshan, which is an initiative to curb this problem. And to enlighten us, we have Dr. Sushma. She is the expert fetal medicine consultant in Telangana, and she is working at Sri Krishna Nursing Home, and she is certified in NT and Fetal Medicine Foundation, and she is the executive member of SFM Telangana chapter, and she is also certified in IOTA, and she is a well-known fetal medicine expert in the Telangana. Over to you, madam.
Namaskar, everyone. I'm Dr. Sushma.
Yes, ma'am. Your audio is fine. You can share the screen.
Thank you very much for your kind words, kind introduction, Dr. Raghavendra sir. Give me a minute, please give me a minute to share my screen. Respected Rajkumar sir, respected special invites. Sorry, can you hear me?
Yes, you're audible, ma'am, and your screen also is visible. You can go ahead.
Okay. Okay, thank you, sir. And my pointer is seen?
Yes, madam.
Okay, thank you, sir. Respected Chief Guest, Dr. Rajkumar sir, and Dr. Ramesh sir, Dr. Hanmantappa sir, and organizers, Dr. Srinivasa sir, Karunakara sir, Vijay Sardi sir, Geeta ma'am, Suresh sir, Srinivasulu sir, and Raghavendra sir, and all the delegates who have joined today. Thank you very much for honoring me with the opportunity to present on World Preeclampsia Day on this prestigious platform of Indian Medical Association, Karnataka State, AMS. My topic today is sequential screening of preeclampsia. Dr. Rajkumar sir and Dr. Raghavendra sir have already given us brief introduction to the problem of preeclampsia. So today I'll be going to talk under these headings, but before we start that, I'd like to ask the attending delegates to please give me some feedback if you are already offering your patients NT scan to all your patients. Can you please type in the chat box with a yes or a no? Okay, thank you, Dr. Disha, for answering. Yes, Dr. Ravi, thank you. Yes. Dr. Madhuri, Dr. Reena, yes, everybody is answering yes. Thank you very much for your response. Thank you. One more question I would like to ask. How many of you are offering double marker screening? So when double marker is first introduced, everyone was so skeptical about it that Indian woman would not opt, she would hesitate for getting double marker done because for Down syndrome screening, it is only 1 in 1,000 and it is expensive. But now everyone has opened up to the idea of double marker and NT scan. Preeclampsia screening is much more important than double marker screening because the incidence is far more higher. So coming back to my topic, I'll discuss it under 3 headings: the background, definition, and burden. But this burden of the disease is already discussed by Raghavendra sir. And next, prediction and screening, and how can we prevent it by giving aspirin 150 mg. First, let's go to definitions. So why am I starting with definitions? Definitely not to bore you out, but there is certain change in preeclampsia definition over the years. As we all know, preeclampsia is hypertension that is occurring after 20 weeks, along with proteinuria. Earlier, the definition was confined to hypertension with proteinuria. But now, ISSHP, that is International Society of Study of Hypertensive Disorders in Pregnancy, this society has given the other option instead of proteinuria if there is maternal organ dysfunction or uteroplacental dysfunction. Very sorry, please give me a second. Very sorry for that.
Problem. You can stop sharing and resharing.
Yes, ma'am, you can go ahead.
Yes, please. Okay, thank you. So not only hypertension that starts after 20 weeks, that is in the second half of the pregnancy, along with proteinuria. So if there is no proteinuria, then it is not like it is not preeclampsia and it is gestational hypertension. Even if there is no proteinuria, if there is any other signs of maternal organ dysfunction, like the kidney injury with raised creatinine or liver involvement with elevated liver enzymes, or even just epigastric pain is also included in the definition of preeclampsia. If the patient is just having hypertension and epigastric pain, still we consider it as preeclampsia. Or if there are any neurological complications like altered mental status, blindness, stroke, all these in the absence of proteinuria and with hypertension, it is definitely called preeclampsia. And hematological complications like low platelet counts, and then without any of these maternal organ dysfunction or proteinuria, even if there is only uteroplacental dysfunction, that is fetal growth restriction or umbilical artery Doppler abnormalities, or if there is stillbirth, it is considered preeclampsia. Moving on to gestational hypertension. Gestational hypertension is if the blood pressure is more than 140/90 after 20 weeks, that is in the second half of pregnancy, and it has to return to normal within 42nd postpartum day. And it is not associated with any of the other complications that we have discussed in preeclampsia, that is either proteinuria or end organ damage or fetal growth restriction. So the most important thing here is it has to return to normal within 42nd day postpartum. Usually it returns within 2 weeks, but at the latest it should return before 42nd day. What does this mean is gestational hypertension can only be detected retrospectively after 42nd day postpartum when there are no other complications arises with the increased blood pressure. So initially after 20 weeks, like for example, at 27 weeks, a patient develops hypertension and there are no other features, we can't yet call it gestational hypertension, because after 2 weeks, again, there can be proteinuria developing or there can be end organ damage that is seen on investigations. So it is mostly a retrospective diagnosis. Then we have chronic hypertension, which is either they are already hypertensive before pregnancy or before 20 weeks, they get the reading of more than 140/90. We have other names like superimposed preeclampsia and eclampsia. Superimposed is if the lady is already a patient of chronic hypertension and after 20 weeks, they have some features of preeclampsia like proteinuria or end organ damage or FGR. So all these names are collectively taken under the term hypertensive disorders of pregnancy. Now, how do we classify preeclampsia? So why am I talking about classification when we are discussing, when my major topic is screening, is because screening is different for early onset preeclampsia and it is different for late onset preeclampsia. For early onset preeclampsia means if it starts before 34 weeks. And late onset preeclampsia is the one that starts after 34 weeks. The classification is important because before 34 weeks, there are more severe maternal complications and severe fetal complications. After 34 weeks, the maternal and fetal complications are relatively less. And based on severity also, there is a classification. One is severe and the other one is non-severe. Earlier, we used to call it mild preeclampsia and severe preeclampsia. But now we have understood that there is nothing mild about preeclampsia. That's why we are only using the word non-severe and severe. So in non-severe preeclampsia, BP is more than 140/90, but not yet reached 160/110, and there are no other premonitory symptoms or other lab abnormalities. Whereas in severe preeclampsia, it should either be more than 160 or there can be premonitory symptoms or abnormal lab parameters. Now, the global burden of the disease is already discussed by Dr. Raghavendra sir. Incidence of the disease is 3 to 5% globally, but in India, it is 10%. That means 1 in 20 women globally, 1 in 20 pregnant women globally develop preeclampsia, whereas in India, 1 in 10 women develop preeclampsia. So around 2.7 crore women deliver every year. So 10% of it is 27 lakh people, they develop preeclampsia. So how to prevent this, how to screen for these women is what we are going to learn in the subsequent slides. And it is the second leading cause of maternal mortality, second only to PPH. So according to WHO, 19% of maternal deaths are happening due to preeclampsia. And every year, around 46,000 women die of preeclampsia. What does it mean? It means every 9 minutes, one woman is dying of preeclampsia. And there are 5 lakh fetuses or neonates dying just because of preeclampsia. So when we go through these statistics, we wonder what can we do about this? Is there a way that we can find out who are the women that are going to die? And is there a way to help them? Is there a way to prevent their deaths? So for prevention, we have this screening protocol first. Screening protocols should be followed according to international guidelines. So what are the international guidelines that we have for screening? There are 2 guidelines. One is NICE guidelines and the other one is ACOG guidelines. What do they say? They divide maternal risk into high risk factors and moderate risk factors. Both of them have the same high risk factors like previous pregnancy having preeclampsia, chronic renal disease, chronic hypertension, diabetes mellitus, and SLE. So both these high risk factors, if at all they are present, they want to consider it as, consider these women as screen positive. And if considering moderate risk factors, if any 2 of these are present, they are considered as screen positive. The screening sounds very simple because you only have to take the history into consideration and you have to see if this is their first pregnancy, that is if she has a primey, what's her age, and what's her BMI, if she is obese or not, and if there is an inter-pregnancy interval more than 10 years, and if the family history of preeclampsia is there. And ACOG additionally considers black or poor women, they have more risk of developing preeclampsia. So they are given more importance, and all these women are given aspirin. But then, is this good enough? When we do not have anything, this seems okay because the detection rate is 40%. So from the 27 lakh women, only 40% women are being detected with this guidelines if you follow only the risk factors. So we might consider 40% as okay when you don't have anything else to do. But then there is this man who have given a better method of screening. Can anyone please name this great man? All of you know this man, but though not directly, because he's the one who has given NT scan to the world. So all of us are already offering NT scan that is given by this man. He's Kypros Nikoloides, Professor Kypros Nikoloides. He's the one who gave NT scan to the world. And not only that, he started Fetal Medicine Foundation and started training people all over the world free of cost through his website and giving NT certifications. The NT certificates we flaunt proudly is given by Fetal Medicine Foundation and signed by Dr. Kypros Nikoloides, sir. So he gave a better method of screening by which we can detect 90% of preeclampsias that are starting before 32 weeks. And before 37 weeks, 75% of the women we can detect. And after 37 weeks, this is term preeclampsias. Term preeclampsias, the detection rate is low, and that is 40%. But we are more concerned with preterm preeclampsias, but because maternal and fetal risks are very high. So what is this method wherein we can detect 90% of preeclampsias that occur before 32 weeks is, according to this method, according to FMF, there is this screening which uses, apart from the maternal risk factors that the NICE guidelines and ACOG have used, apart from the maternal risk factors that include age, obesity, the race. In race, important thing to consider is Black women and South Asians are having very high risk of developing preeclampsia. That's why global risk, when it is only 5%, Indian risk is more than 10%. So taking all the factors into consideration, risk factors, apart from that, there are 3 other factors that are being considered. One is uterine artery Doppler. First trimester uterine artery Doppler during NT scan time. And then taking mean arterial blood pressure of both the arms. And then doing biochemical test of PLGF. Again, uterine artery Doppler is also given by Professor Kypros Nikoloides. We need to take at the level of internal os, just lateral to it, right and left uterine arteries. Both the uterine arteries are sampled with a sample gate of 2 mm. And this uterine artery Doppler, we need to take a mean PI. Right uterine artery and left uterine artery, both the values are taken and mean PI is to be taken. After Dopplers, then we have mean arterial pressure. Mean arterial pressure, routinely we only measure one arm reading, but mean arterial pressure should be taken of both the arms, and then MAP is calculated by taking the average of systole and diastole readings. There are certain guidelines in taking this mean arterial pressure. Hands should be at the level of heart, and the hand should be supported on a table. Legs should be uncrossed, and patients should be sitting quietly. All these should be followed. Then this is biochemical analysis with PLGF, that is placental growth factor. What is placental growth factor? It is synthesized by the placenta, and it helps in angiogenesis. So when we take all these 4 into consideration, and then I'll just want to show, there is this fetal medicine website wherein we can put in all the values that we have till now. If you open fetal medicine website, on the page we have calculators. In the calculators, if you take preeclampsia calculator, you can type in all the values that we have so far. You can take pregnancy as a singleton, and CRL, I want to take it as 70, which is around 12 weeks, 13 weeks. And then examination date, if we take it today, we have all these values that we need to fill up. Some of them I have already taken the medical history as no significant history. I have filled this up prior just for time saving. Now here, this is important, racial origin. You need to click on South Asian origin and take the mean arterial pressure. Now, how to calculate mean arterial pressure? It is not the direct average of systole and diastole. If it is, we'll come back to that. But I'm giving all the values in the normal ranges except mean uterine artery PI, where I'm giving the mean uterine artery PI as high. 2.4 is considered high. And if we do not have biochemical measurements also, it will calculate the risk. So biochemical measurements, you can calculate. If you actually do double marker enhanced first trimester screening, you can include PLGF along with PAPE. But if you don't have the values also, you can calculate the risk. Now, this has given me the risk of this woman, and the risk, preeclampsia risk, only if we consider history, like we have taken from NICE guidelines. If you take only the history, the risk is 1 in 185. 1 in 100 is the cutoff. So this shows as low risk. But now that we have used mean arterial pressure and uterine artery PI, the risk given is 1 in 68. So less than before 37 weeks, this lady has the chance of getting preeclampsia of 1 in 68. And it recommends, the recommendation also is given that according to aspirate trial, 150 milligrams aspirin should be given at night. Can you see my screen?
Yes, we can see.
Yes.
Okay, thank you, ma'am. So low dose aspirin, that is 150 milligrams, should be given at night from now, that is now she is 13 weeks until 36 weeks to reduce the risk of preeclampsia, that reduces the incidence of preeclampsia before 32 weeks by 90%. This is a very significant reduction in the risk by giving 150 milligrams of ecosprin. So as already discussed, once we calculate the risk, once we know which women are going to develop preeclampsia, we can do prevention. And the best preventive measure so far that we have is ecosprin 150 mg. This is proved by this aspirate trial. And this again is done by Fetal Medicine Foundation by Professor Kypros Nikoloides and Leona Poon. They have given aspirin. What did they do? They have taken around 27,000 women, and they have screened between 11 to 13 weeks by the factors that we have said before, like in the preeclampsia risk calculator that they have used. And they have taken high-risk women and assigned them into aspirin group and placebo group. Around 1,600 women are detected in total, and around 800 are given aspirin, and around 800 are given placebo. And what is the dose of aspirin? It is 150 milligrams per day between 12 to 36 weeks. And they have seen a significant reduction, 90% reduction in preeclampsias developing less than 2 weeks in aspirin group compared to placebo group. So this trial has proven beyond doubt the benefit of aspirin 150 milligrams. Before this trial, there were so many other trials that gave conflicting results on aspirin's efficacy. And that was because they have used less dosage of aspirin, like 75 mg of aspirin instead of 150. And also they have used aspirin. They have started giving aspirin after 20 weeks, some after 25 weeks, and so on. So none of them started aspirin before 16 weeks as these people, Aspray people, have done. And now if we see less than 32 weeks, preeclampsias, 90% are reduced. And early onset preeclampsias, that is less than 34 weeks, 82% are reduced. And preterm preeclampsias, that means before 37 weeks, 62% are reduced. But then after 37 weeks, term preeclampsias, there is not much reduction. There is only 5% reduction, which is not significant. So this is not working on term preeclampsias as much as it is working on preterm preeclampsias. And in preterm preeclampsias, there is 62% reduction is what they have got in the preliminary study. But then in the secondary analysis of Aspray trial, the same trial, after preliminary study, they have done secondary analysis, and there they have excluded certain things like women with chronic hypertension are excluded, and only complaints with more than 90% complaints, women who has taken aspirin more than 90% of the times, if they have included that, aspirin actually reduced the rate of preterm preeclampsia by 95%. So in contrast to the original 62% reduction in less than 37-week preterm preeclampsia, it actually reduced 95% of preterm preeclampsia. Isn't that wonderful? And isn't that what we want? So this is a quick recap of so far what we have done. So first we have to do first trimester screening. And these are the 4 things that we have to take into account. One is maternal characteristics, including her history, if she is a primey or not, and if she has, what is her race, and if she has previous history of preeclampsia and any chronic hypertension, all those we have to take into account. And then take mean arterial pressure of both the arms and uterine artery PI by Doppler during NT scan time, and take biochemistry of PLGF. So when you take all these, and whoever is in high risk, if you give aspirin when at bedtime, it should be given only at bedtime. Why specifically bedtime? Because most of the vasospasm episodes happen during night, early morning hours between 4 to 6 a.m. So that is the reason if you give 150 milligrams at bedtime, it prevents these episodes. And when should we start it? We have to start it before 16 weeks. And if you start it after 16 weeks, the effect is relatively less. So now we have predicted preeclampsia, and we have prevented in nearly 95% of women in whom we have predicted. So are we happy so far? Compared to NICE guidelines and ACOG guidelines, which predicted only 40% of preeclampsias, FMF guidelines are predicting around 90%. So this is a quick recap again, including maternal risk factors, uterine artery Doppler on ultrasound, mean arterial pressure, and PLGF. With that, we are reducing at least the detection rates. Reduction is 62% in the initial trial, but 95% in the subsequent analysis, secondary analysis. And also we are detecting 90% of women before 32 weeks. and 75% of women before 37 weeks. So are we happy so far? Maybe I am happy, but Professor Kypros Nikoloides, he is not yet happy. And he doesn't want to miss the remaining 10% of women who are missed in this screening. So what do we have next? And also he doesn't want to miss term preeclampsias. We all know term preeclampsias are very milder compared to preterm preeclampsias. So what is the point? What is the harm in missing term preeclampsias? So according to Professor Kypros Nikoloides, in his study population of 40,000 pregnant women, preterm preeclampsias are seen in 300 women and term preeclampsias are seen in 1,200 women. That means it is 4 times as high as preterm preeclampsias. So even though severity is less, the burden of the disease is very high. So, and severe hypertension occurring is seen in term preeclampsias in 74% of the times, compared to only 26% of the times in preterm preeclampsias. And in term preeclampsias, maternal mortality and morbidity is still significantly high. So in maternal mortality and morbidity, 54% is being contributed by term preeclampsia just because of their sheer numbers. The remaining 46% is contributed by preterm preeclampsias. So now what do we understand by this? Term preeclampsias is not as mild as we think. In the beginning, as we said, preeclampsia is not mild. It is either severe or non-severe. So even term preeclampsias are not mild. They contribute to 50% of maternal mortality of preeclampsias. And to the perinatal mortality, only 23% they contribute because already neonates are term by then. So that's why only 23% perinatal mortality is contributed by term preeclampsias, whereas the remaining 77% is contributed by preterm preeclampsias. And this is NICU admissions and birth weight less than 3rd percentiles. So term preeclampsias also should be screened for. Then how do we predict term preeclampsias? This is done by, so please focus only on this line. Mean arterial pressure if you take, and uterine artery PI if we take, and PLGF along with SFLT1, that is SFLT1, we can predict 78% of term preeclampsias. And when should we take all these measurements? Not at 12 weeks, but at 37 weeks. So this is called sequential screening. At 37 weeks, if we do again mean arterial pressure, uterine artery PI plus PLGF and SFLT1, we can predict 78% of term preeclampsias and reduce the morbidity and mortality caused by term preeclampsias as well. So what is SFLT1? It is an anti-angiogenic factor, whereas PLGF, that is placental growth factor, is an angiogenic factor. Both of these are derived from placenta only. Placenta gives platelet growth, placental growth factor, which is an angiogenic factor and which is a good one. Whereas SFLT1 is an anti-angiogenic factor, which is a bad one. If PLGF is high, it is good for the mother. If SFLT1 is high, it is bad for the mother and it makes the mother prone to preeclampsia. So that's why ratio of SFLT1 and PLGF is taken in calculating the risk for preeclampsia, and the ratio should be less than 38. If it is more than 38, that means SFLT1 is more and it is an anti-angiogenic factor and it is making the woman prone for PLGF. So brief pathogenesis. I did not include the pathogenesis in the initial part of the presentation, and I included it now because I have to tell you about SFLT1 and PLGF. As we all know, in non-pregnant women, spiral arteries are very narrow arteries that are coming from radial vessels. So these spiral arteries are very narrow in non-pregnant women and offer maximum resistance. Whereas in normal pregnancy, these spiral arteries are invaded by trophoblastic cells, maternal trophoblastic cells, and they dilate these spiral arteries and give sufficient blood supply to the placenta. In preeclamptic women, this invasion is not proper and the dilatation of the spiral arteries is not good enough, as we all know, and this leads to preeclampsia. And this placenta, which is not properly developed, releases SFLT1, whereas this placenta releases PLGF more, and preeclamptic placentas releases SFLT1 more. This is a normal pregnancy endothelium, vascular endothelium, and this is a preeclamptic pregnancy vascular endothelium. So what happens is, here if you notice, these are SFLTs. These SFLTs will take the positive. These SFLTs are bad, as I said earlier. These catch up the good PLGF and VEGF. VEGF is vascular endothelial growth factor and it is also good. So this SFLT catches up the good PLGF and vascular endothelial growth factor, and it doesn't leave any of the PLGF for the vascular endothelial cells for their growth and maintenance of their proper integrity. Whereas in normal pregnancies, PLGF is attached to the vascular endothelium and it maintains the proper integrity of the vascular endothelium. Here, when the vascular endothelium is not properly maintained, it is damaged and leads to all the secondary complications of preeclampsia and the maternal end organ damage. So only one thing you can remember here is that SFLT is bad and PLGF is good. And the ratio of SFLT and PLGF helps us in determining if the woman is prone for preeclampsia. And one more thing is, SFLT is released into the maternal circulation and the values are raised more 5 weeks before the onset of preeclampsia. So that's why SFLT cannot be used in first trimester screening. Why? Because it is only released 5 weeks before the onset of preeclampsia. So the machine, this machine that calculates SFLT by PLGF is given Time Magazine's Best Innovation of 2023 award because it is helpful in preventing preeclampsia. It is helpful in predicting preeclampsia and thus preventing it. Now, what is sequential screening? So far, we have seen screening in first trimester, that is at 11 to 13 weeks, which most of us are already doing by uterine artery Doppler and taking the maternal characteristics. And of course, mean arterial pressure is a difficult part because we are in our busy OPDs, maybe sometimes we are not calculating it properly. But almost all of us have got used to the idea of first trimester screening for preeclampsia. Now, the sequential screening is to catch hold of the missed 10% of women during first trimester screening. So when should we do this? So that is when we do our next scan, that is during anomaly scan. So now at 11 to 13 week screening, by using mean arterial pressure, uterine artery PA and PLGF, we are catching hold of 90% of preeclampsias, early onset preeclampsias. That is at 11 to 13 weeks. So to detect the remaining 10% of preeclampsias here, we can do screening again at 20 weeks. So even at 20 weeks, majority of us are already offering uterine artery Dopplers. If you do screening at 20 weeks, we can detect 100% of preterm preeclampsias that are occurring before 34 weeks. And this 100% detection rate is achieved by using not only mean arterial pressure, uterine artery PI and PLGF, but also to include SFLT1. Because as we discussed, SFLT1 only increases 5 weeks before the onset of preeclampsia. That's why it is not increased during 12 weeks, and we only include it at 20-week scan, 20-week screening. Okay, now that we have detected 100% of preterm preeclampsias, are we convinced with this mode of screening? So even this is not enough for Professor. Then we have the next screening at 32-week scan. So after anomaly scan, we do our next scan at growth scan around 30 to 32 weeks. That is when we can again screen by mean arterial pressure, uterine artery PI, and biochemical markers. And in this, we are going to detect 98% of preeclampsias that are occurring before 37 weeks. If I go back a slide, as you can see here, even despite doing first trimester screening and second trimester screening, we are not detecting all the preeclampsias that are occurring before 37. Between 34 to 37, we are missing around 15% of patients who are developing preeclampsias. So in order not to miss a single woman developing preeclampsia, we can even go and increase our testing further and do the screening even at 32 weeks. So what are we achieving by doing the screening at 32 weeks? We are getting nearly 98% prediction of preterm preeclampsias. And this is still not enough, because term preeclampsias, which are occurring after 37 weeks, we are able to detect very less. Okay, only 55% of term preeclampsias we are able to detect. So how and when to screen for term preeclampsias? Term preeclampsias, we cannot detect better at 32 weeks because SFLT1 is not yet raised for term preeclampsias. So when should we do the screening for term preeclampsias? We should do it at 37 weeks, right before term. Now, if we do first trimester screening, second trimester screening, and during our first growth scan screening, and during our second growth scan also, if we incorporate screening, we are almost detecting 84% of term preeclampsias and almost 100% of preterm preeclampsias. So isn't this wonderful? Every 9 minutes, one maternal death that is happening, we want to focus on every individual maternal death and stop and prevent those deaths happening. Instead of just 40% detection rate, just 70% detection rate, we want nearly 100% detection rates. But then this sequential screening, it doesn't look practical and feasible in the current scenario. As in the same way as double marker did not look feasible 20 years back when it was introduced. So as we have moved forward and incorporated double marker into our routine screening, in the future, there is a possibility that we can incorporate all this sequential screening at 12 weeks, 22 weeks, 32 weeks, and 36 weeks into our screening strategy and prevent maternal mortality occurring because of preeclampsia. So what do we do once we detect term preeclampsias? So before that, this is the Bayes theorem and fetal medicine foundation theory that all the women are prone to develop preeclampsias. All the pregnant women are prone to develop preeclampsias only if the pregnancy continues inevitably, beyond 56 weeks of gestation. Thankfully, the pregnancy is delivered at 40 weeks. Pregnancy is terminated at 40 weeks. That's the reason majority of the women are not developing preeclampsias. Why is this? Because of the placental maturation and aging. So that is the reason only 2 to 3% of women are developing preeclampsias. In low risk women, this curve is shifted to right, whereas in high risk women, this curve is shifted to left. And this curve is shifted to left because of some immunological factors and genetic factors. Our aim is to detect these women whose curve is shifted to the left and give ecosprin starting from 12 weeks onwards till 36 weeks, 150 milligrams, and move the curve to the right. And once the curve is moved to the right, we prevent preterm preeclampsias and even term preeclampsias. And once we detect term preeclampsias, what is it that we can do? Obviously, we cannot give ecosprin at 37 weeks and hope that that will work. But what we can do is, instead, we can offer personalized timing of birth at term. Once you know that this patient is going to develop preeclampsia at term, you don't want to wait till 40 weeks or beyond 40 weeks for spontaneous onset of labor and finally fall prey to preeclampsia. What we have to do is we have to give them personalized timing of birth at term. So this is what Fetal Medicine Foundation proposes. Once we detect term preeclampsia prone patients, then we assess the risk at 36 weeks. And if the risk is too high, that is, if the risk is 1 in 2, then we deliver them at 37 weeks. If the risk is not very high, but high, like 1 in 5, we deliver them at 38. If this is intermediate risk, then they are delivered at 39. If it is low risk, that is 1 in 50, then we deliver at 40 weeks. And if it is very low risk, we can wait till 41 weeks. Thank you everyone for your patient listening. Hope one day we can achieve this kind of intensive screening strategy and intensive prevention of preterm and term preeclampsia and reduce our maternal mortality to near zero.
Yes, thank you, Dr. Mehta, for the excellent presentation. So it was very simplified too. It was very good. Yeah. If anyone has any doubts, kindly unmute and ask, or you can type in the chat box. Yeah, only the thing is now cost effectiveness, because these tests are a little bit costlier at present. For us to repeat them
Yes,
4 times, 4 times, it will be a little difficult, like 12 weeks, 20 weeks, 32 weeks, and 36 weeks. Or maybe what we can do, the patients who are having past history, for them, we can repeat it optimally. So if any past
yes,
loss is there.
This is only what best we can do, ma'am, but not what we can currently implement it. So, but this is what the opportunity we have, and maybe one day in the down the line, maybe we can do this. So at least first trimester screening, all of us are doing.
All are doing.
And, yes, ma'am. And with that second trimester uterine artery PI also, most of us are doing. And if we include these two, most of the preterm preeclampsias we are ruling out.
So taking her past history, if she has a loss or any bad obstetric outcome in the previous pregnancy, accordingly, we can again do the second screening. Like if she had a loss in the later weeks, maybe 32 weeks we can do. So that way we can optimize and see how customize our screening to see that with minimal costs we can do it. At present,
currently the cost for this proposed screening is too high that it is not possible to implement right away. But down the line, sometime maybe the lab company, the lab people might reduce the cost and give it. And as I mentioned, 20 years back, we never thought that our women would opt for double marker screening.
Yes.
So now women are actively, opting in for double marker.
Yes. Yes.
And the hesitancy in taking that expensive test is not seen much in the women, but rather I see the hesitancy in the gynecologists who are offering the test.
True.
Only the gynecologists are hesitating to offer the test because it is expensive. I mean, double marker test, but the patients are not hesitating. Most of them are opting in.
Yeah, it's true.
So it is, I think we should give the test to the patient, at least double marker for now. And maybe in the future down the line, we can include these tests as well.
Yeah. So first we should be convinced. We gynecologists should be convinced. And
patients
let
are
me
ready to accept. So when they want to take it, not everyone, I agree, not everyone, because we have a varied demographics from government sector to very high-end private sector.
Yeah.
So we should be ready to offer it.
True. But at least those patients who are affordable and willing, we can give an option to them.
Option,
And usually
yes.
for any test, what happens? The more the people we test, the lab rates come down. So the more widely the tests are used, the cost comes down definitely. So if we start using for the affordable patients, maybe down the line, we will get at lesser costs. Yeah, we have few questions in the chat box. Yeah, Dr. Chandni is asking, ma'am, regarding time of delivery, screening risk as per early screen risk or at term screen risk?
Ma'am, this is timing of delivery. The last slide that I have shown you, if you are asking about that, that is for term preeclampsia. Once we screen them off at 36 weeks also. Because in preterm preeclampsias, anyways, they will be delivered by then. Only thing is term preeclampsias, if we predict, we have late stillbirths like at 39 weeks because of abruptions that happen because of term preeclampsia that just developed. So that we can avoid.
Yes. So one more question we had. What parameters to look for in third trimester screening?
So in third trimester screening, always maternal characteristics to be taken in all times, at all times, and mean arterial pressure to be taken at all times. And in third trimester screening, actually uterine artery PI is dropped out because including it or not including it is not changing the statistics. So only SFLT and PLGF ratio is added to the regular mean arterial pressure and maternal characteristics. So for now, I think if we are not including the biochemistry, we can just at least include mean arterial pressure and maternal characteristics and decide on the timing of delivery.
Yes. What Dr. Prakash is asking, what is the cutoff for mean arterial pressure?
It is not cut off, ma'am. We have to put it in the calculator as I have shown.
Yes.
We just have to calculate the mean arterial pressure. And how to calculate mean arterial pressure is, in the simple way, if the if the blood pressure is 110/80, we think we can take systole and diastole and take average of it. But then mean arterial pressure is not average of systole and diastole, but it is average of 1 time systole and 2 time diastole. So once SBP value plus 2 times diastole value divided by 3. Why is it? Because cardiac phase is more in the diastole than in systole. So that anyways, we need not calculate. We have apps to calculate mean arterial pressure. If we just put systole and diastole value, it gives mean arterial pressure. And as I have shown you earlier, as I have shown you earlier in the calculation of the risk, is my screen still seen, ma'am?
No.
So as I've shown you here, we just have to put in the value here, mean arterial pressure value. And this is a free of cost calculator for everyone that is available in the Fetal Medicine Foundation website. And here, if you click on calculator, there is this preeclampsia screening at 11 weeks, at 19 weeks, and also at 30 to 37 weeks. So we can just click on this calculator and put in the values and do the risk assessment. And it will automatically give us finally what is the advice. So biophysical measurements, mean arterial pressure we can include here, and biochemical measurements we can choose not to include here, as we are currently not doing these yet. So we can only give the maternal characteristics and mean arterial pressure and calculate the risk, and it will give us the probable estimated time
Yeah. We have one more question. What is the significance of gestosis scoring in preeclampsia?
Yes, ma'am. Very good question. Gestosis scoring is actually this has come up by our Indians. I have a few slides on it as well, but because of shortage of time, I did not share those. Is it okay if I share it now, ma'am?
Yeah, it's a fraction of second, like 2-3 minutes we can discuss
Yes,
it.
ma'am. Only 2
Yeah.
minutes.
Yeah. We have Dr. Vasanta ma'am, who was the past AMS chairman of Telangana, who has joined, and she has congratulated Dr. Sushma for a very nice talk. Then we have our senior most obstetrician from Mangalore, Dr. Vasanti Shetty madam, who has also joined us today. Madam is very senior most. She's from Mangalore, and still madam always joins all the CMEs very actively.
Ma'am, this is gestosis score.
Yes.
And it is developed by Indian Innovation. This is developed by Dr. Gorak Mandrutkar sir, and it is modified by Dr. Sanjay Gupta, Dr. Suchitra Pandit, and Dr. Alpesh Gandhi and Dr. Girija Wagh. This is purely on maternal characteristics. In the setting of low resource setting, we cannot do, if we are unable to do uterine artery Dopplers, if we are unable to do PLGF and SFLT1, they have given a scoring system. So according to that, they have divided it into mild risk, moderate risk, and high risk. In high risk, we have all those that we have discussed earlier, like diabetes, chronic hypertension, mental disorders, and acquired thrombophilia, chronic kidney disease, and autoimmune disease, and IVF pregnancies. All these, they give a score of 3. So this is a scoring system that is to be used in low resource setting. But I think we are already moved on to first trimester screening, and we are already using uterine artery Dopplers. So these are for those who are not even affordable for those uterine artery Doppler patients. So this score, this is moderate risk factors, wherein you take these factors as score 2, and these are mild risk factors where you give in the score 1. And here the cutoff score should be 3, ma'am. Total score, if it comes as 3, then you definitely have to give them ecosprin.
Okay.
And so any of these is there, we definitely give ecosprin, because each individual one is 3. And if any of these is there and more than 1 together, all combined, if it is 3, we can start ecosprin.
So how good is it in predicting the preeclampsia?
In
Like
predicting preeclampsia, wide studies are yet to be done, madam. We have accepted this because in our scenario, as we have said, we have variable people from government sector to private sector, high-end private sectors. So for those who cannot afford the screening, the basic screening of uterine artery Dopplers and all, for them we can offer, at least instead of doing nothing,
something we can
do the maternal characteristics in a better way than given by ACOG and NICE guidelines.
Yeah.
These maternal characteristics are much better than those guidelines.
Yes. And definitely we are going to treat them with ecosprin only. So
ecosprin.
And we can be little liberal in giving ecosprin because it will not cause any side effects or any problems to the patient. So definitely we can be a little more liberal. Yeah.
Yes, relatively liberal.
Yeah.
But ecosprin can cause antepartum hemorrhage and postpartum hemorrhage if used without caution.
No, but in our experience, we are not, because it's very low dose, no? Hardly it causes any problems.
Yes, ma'am. 150 mg.
Earlier we used to give 75, but now we are all 150 only.
Yes, ma'am. Ma'am, in your experience, after you moved on to 150 mg, have you noticed a drastical decrease in preeclampsia?
Not drastic, but yes, definitely it is less. What was our concern is early weeks, what happens? They are not able to tolerate it. 150. So that's why we used to reduce it to 75. Those patients who are able to tolerate, we definitely give them 150. But most of the time, because this nausea, vomiting, hyperemesis, all these things will be there. No, 12, 14 weeks, 16 weeks, few patients have. They're not able to tolerate 150. So that's why we used to give 175. But now, 75. But now we are moved to 150 only. Yeah.
So this one single move from 75 to 150
Yes.
has
Yes,
changed.
definitely,
so much.
it is very useful. Yeah, it has definitely reduced, and we are little liberal in starting it. So though we are not doing all these tests also, uterine Doppler and even just past history, all the maternal characteristics we see. Yeah.
Yes, ma'am. We can take and we can include mean arterial pressure, ma'am.
Yeah, mean arterial pressure also we can start. Yeah, true. So I think very exhausting and very nice talk. So now we come to an end. So do we have Dr. Suresh Kagalkar, sir? You're there? Dr. Suresh Kagalkar?
Yeah, madam. Yeah, madam.
Yes, sir. The sir is the Honorary Secretary of Ima Ams Karnataka State. Sir, I request you to propose the vote of thanks.
Thank you, Geeta madam, for giving me the opportunity to give vote of thanks. First of all, I have got one doubt, madam. Sushma madam, what are the hello?
Yes, sir.
Yeah.
Yes.
Yeah. What are the government benefit regarding the high risk? How we can explain? How we can counsel the patient, especially the patient from the periphery who is coming? So, what are the government benefits, especially the state-wise? The different benefits are there. So, how we can do the high risk the pregnancy? How we can screen and what are the benefits under the government scheme?
Sorry, sir. I do not work in the government sector, so I think.
Sir, but usually, sir, in the government setup also, sir, they have USG machines now, sir. Good USG machines are there. They are doing NT scan and anomaly scan. All the scans are done in the government setup also, sir. They are
That is
screening
what
the patients, sir.
there is some suraksha some government scheme is there. So for any high risk pregnancy, if you send from the periphery, they'll give some beneficiary monetary amount. That is the one thing. Second thing is as a private setup, whenever there is high risk pregnancy is there. So if we refer from the government hospital to if the patient wants to go to the private hospital, there is also some amount of benefit, monetary benefit or amount is there. So regarding this, our director will give us some light. Dr. Raj Kumar sir and Ramesh Babu sir. Sir.
I think you're talking about Janani Suraksha Yojana, but that is, I think, regarding the delivery.
So she must be knowing some different schemes in their state as well as we want to know what are the government schemes in our state. Whenever high risk pregnancy is referred or high risk pregnancy is referred to the private hospital, or is there any?
Yes, sir. We will have to discuss with the government officials only, sir, because because we can know basically, but not in depth about this. But definitely, all the CHCs are having, and definitely district hospitals, all are having an ultrasound machine where the women are screened.
Yeah. Okay, madam. Thank you.
That is our target. Like we have to prevent preeclampsia. So screening and treat ecosprin. That basic if we do, we are going to do reduce lot of morbidity and mortality because of preeclampsia.
Yeah, thank you, Dr. Sushma madam. All the way you have come and delivered a very good topic. And this is on this auspicious day. There are 2 days which are included in today's seminar. One is World Hypertension Day. Especially the hypertension means it includes in general, maybe a physician, maybe a cardiologist, or maybe anybody, gynecologist, obstetrician, or in general. And another one is the pre-eclampsia day. So these are good topics, and the many number of audience, more than 50 members are joined, and it is a very good topic under the auspicious of our IMA AMS. So we are doing such a good, wonderful program along with the Balaya branch, and the madam has come from all the way from Sushma madam come, and you are delivered good talk, and especially the forum is very interesting, and many people have interacted, and especially regarding the fetal medicine. Thank you very much, Madam Sushma madam, on the behalf of IMA and IMA KSB and IMA AMS. So AMS is always doing some such different programs in the every month. So we are calling all the different chief guests and especially speakers. So they delivering the different talk on the different topics. Thank you very much, Sushma madam, once again on the behalf of IMA KSB AMS. And also,
thank you very much, sir. An excellent opportunity for me. Thank you, sir.
Yeah, thank you, madam. And also, I would like to give thanks to our chief guest of today's function, Dr. Rajkumar sir, who is a deputy director of our Health and Family Welfare Department, and with her presence has made our prestigious IMAMS to more and more information to our practitioners as well as all the members of the IMAMS KSB also. So, thank you very much, sir, Rajkumar sir, and you have come and you have chaired the session. And similarly, I must give thanks to the Dr. Ramesh Babu sir, who is a district health officer of the Ballari branch, Ballari district. Dr. Ramesh Babu sir also, I must give thanks on the behalf of IMASB, KSB, as well as IMAMS. And Dr. Hanumanta sir, also I should give RCH officer from the Ballari. So thank you very much for joining and conducting very good session. This is important session, especially all the practitioners, especially the gynecologist and obstetrician, and all the PG students also joined. And thank you very much, sir, Harmantap sir. And similarly, I must give thanks to our important person behind the today's function, who has given opportunity, Dr. Srinivas sir, who is a president of IMA KSB. Dr. Srinivas sir, thank you very much for joining and giving an opportunity to conduct such a good important program. And another important person, that is the secretary, Dr. Karunakar sir, who has also joined and given regarding the prayer. And Geeta Dappa madam, our chairman of IMAMS, always doing the different wonderful programs. And next month we will do another program with a different topic with the same time. Thank you, Geeta Dappa madam. You have given opportunity for me to conduct this program under my secretary post. And one more is that Dr. Raghavendra sir, who has given perinatal morbidity. What exactly perinatal mortality and perinatal morbidity? So you have also told under your guidance, and this program has guided very well. Thank you very much, sir. And I must say thank you to all the chairpersons, as well as the different branches under the IMA KSB, maybe public health or especially our doctors, Vaidya group, that also. So anybody who has joined, all the members, I must thank you to everyone. And with this, we'll end up the program.
Yes,
And
sir, thank you to President of IMA Ballari, Dr. Srinivasalu sir, who is present with us and helped us in organizing this program.
President and Secretary of IMA, yes, sir, Ballari branch, who has come forward and also made along with IMAMS. So both joining together, we have conducted such a wonderful and good program, and it is success program. Success is mainly because of a good audience. So good audience is because of good interaction. Good interaction mainly because of the interest of the audience as well as the speaker. Speaker is very well motivated and told. And thank you very much for joining, everyone. And if anybody left, also excuse me, and thank you everyone for joining, and also YouTube viewers. So many people after the program, they will view the program. They will have a different opinion. Also, they will give opinion, and anytime they can discuss with us or anybody of the IMA KSP, madam, or anybody. So thank you and welcome everybody. And with this, we'll end up the program. And good night. We'll see the next month with a different topic and a different speaker. Thank you everyone. Madam.
Yes, thank you. Yes.
Geeta, madam. Thank
Yes,
you.
yes. Yeah. Thank you. Srinivasalu sir, because of the paucity of time, I did not give you opportunity to talk actually,
no problem.
because we are running short of time. And
No
thank
problem.
you very
It
much.
was very
sir.
nice. It was very nice. I checked the YouTube also.
Okay,
there were some 30 members who were viewing through YouTube also.
Yes, sir.
In
Yes,
addition to this, anyway, this is a very timely thing, and
yes, yes,
session was very informative. Hope we will take this forward.
Yes, sir.
And IMA Ballari would like to associate with such programs more and more. Hope we will do some more programs in the.
Yes, thank you so much, sir. And we have the YouTube recording. Tomorrow again, we'll send the link to the people who have missed it, sir. And definitely it will be really helpful to every one of them. Yes, sir.
Thank you very much. Thank you. Thank you. Thank you, madam.
Yes.
Thank you, ma'am.
Thank you once
sir.
more,
Thank you.
Dr. Mehta, for the excellent talk. And thank you, Dr. Raghavendra, for organizing everything, because he has done everything. Just we were there to just present it, because he has spoken with you, all the guests. He has done a lot of efforts. Even last year also on World Pre-Eclampsia Day, we had done the Samrakshan program. So that also was a very nice program. So definitely every year we'll try to see that how we are going to reduce the morbidity and mortality because of pre-eclampsia. Yeah. Thank you. Thank you one and all. Yeah. And thank you, Dr. Sangeeta, for the introduction of the chief guest. Sangeeta, you're there? Yeah. So thank you one and all. Thank you all the viewers who have joined in large numbers, and hope we carry home the take-home message, whatever we have got in reducing the maternal mortality and morbidity. Thank you one and all. Good night. Yeah. Thank you, John, for your help. John, are you there? Yeah. Okay.